Okay, hello everybody and welcome. My name is Stephanie Harvard, and as you can see from my background, I'm joining from the University of British Columbia, which is located on the traditional and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh people. Please feel free to use the chat to acknowledge the lands that you're coming from. So I'm going to be the host for today's event, which is the first installment of the Lungs on Fire 2025 speaker series. And for those of you who maybe are not totally familiar, the Lungs on Fire project is a 5-year team grant that's being funded by the Canadian Institutes of Health Research. And it's being led by Dr. Chris Carlston and his team. Chris Carlston, for those of you who may not know, is the head of respiratory medicine at UBC, and he's the director of legacy for Airway Health, which is part of Vancouver Coastal Health Research Institute. That's where I'm based as a researcher and the co-chair of the Lungs on Fire Knowledge Mobilization Working Group. Now, in addition to myself and I think a few others here today, Dr. Emily Brigham, who we were speaking to before, Dr. Stephanie Cleland, Lungs on Fire involves numerous other scientific investigators and organizational partners from across BC and Canada. And the major goals of the project are to help understand the longer-term health effects of wildfire smoke, and also how to improve public health guidance on this subject. So that brings us to today's topic. So as we know, the question of how to improve public health guidance is ultimately a normative question, and it depends in large part on what we take to be the goal of the guidance. Now, that goal is likely to be shaped by ethical, political, and other considerations. So to help us think through these issues, we wanted to engage with a philosopher, and specifically a philosopher of science and medicine with expertise and experience in a range of scientific and ethical topics. So we have with us today Jacob Stegenga, who is a philosopher of science and medicine, a professor now primarily based at NTU Singapore after having spent the last many years at the University of Cambridge, where I think you're still affiliated. Professor Stegenga is the author of the critical work Medical Nihilism, as well as the textbook Care and Cure, An Introduction to the Philosophy of Medicine, as well as Heart of Science, his upcoming third book. Now, what we're inviting Jacob to do today is twofold. First, present an argument about what the goals of public health guidance should be. Second, engage with all of us on a debate about this contentious topic. So I'm going to invite you all to take notes on the talk that he gives today and to consider whether you agree or disagree on his position or various aspects of it. In the discussion session today, we will be taking questions both through the chat and with the raised hand function to make sure that we're giving as many opportunities as possible to people to share their views and engage with Professor Stegenga. I'll be acting as a moderator, and I'll be limiting speakers, sort of using my judgment when it seems like perhaps we should move on to the next question. So I hope that session will go well, and we'll sort of work our way through it together. So with that, please join me in giving a very warm welcome to Professor Jacob Stegenga. Thank you so much for being here.
Thank you, Stephanie, for that. I'm going to try sharing my screen. Is that coming through?
It is for me.
Great. Okay. Thanks for that kind introduction, Stephanie. I'm really glad to be invited to this venue. In general, philosophers of science and medicine love sharing their work with scientists and medical scientists and public health practitioners. So it's a great opportunity for me. And it's kind of a special moment for me too, because there's a sort of secret from my past, which is before I finished my PhD, I in fact worked in public health. I worked for the Public Health Agency of Canada. And there was this moment when I had a job offer from the Vancouver Children's Hospital, and I had to decide, do I take that job or do I finish my PhD? And, ultimately I decided to finish my PhD, but it was a really sort of, critical moment in my past. So now I'm revisiting public health in British Columbia. Another reason why I was really happy to get this invitation is that when Stephanie invited me, I thought, oh, this is going to be so easy. because the guiding question has the answer built right into it. What's the goal of public health guidance? Clearly, the goal of public health guidance is just to improve public health. So I thought my job was going to be really easy. But of course, as Stephanie already noted, some of the key notions here, public health and guidance, are very complex conceptual notions and normative notions. There's underlying ethical and political dimensions to each of these concepts, and they intersect in really complicated ways. So the more I thought through the topic for today's discussion, the more perplexed I got. And so I will be offering something like an argument, but not an argument that philosophers are used to. So I won't be sort of like pressing one very specific thesis that guides the whole talk. Rather, what I'm going to do is I'm going to briefly touch on the notion of health, on the notion of the public, and on the notion of guidance. And I will give an argument on each of these notions. But at least for the first two, it's more going to be kind of opening up a space for discussion. I'm going to move really briefly through health. I'll speak to that first. A little bit less briefly on the public, and I'll spend most of my time speaking about this notion of guidance. And there, with guidance, I'll be giving a bit more of a focused thesis. That's a topic that I have a bit more of a well worked out view on. Okay, so first health. As many of you know, this is sort of part of your bread and butter. The notion of health is contested. So here's arguably the most famous definition of health from the World Health Organization. So this definition is very expansive. Many commentators note that this definition is sort of all-encompassing. So WHO says health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And what many commentators note is that with this definition at hand, the goal of health promotion becomes expansive. So a wide range of different kinds of policies are brought into the remit of health promotion and public health. A very different kind of definition. It's not as famous as the World Health Organization, but among philosophers, it's very well known. This is probably the most well-known definition of health that comes from philosophy by the philosopher Christopher Boorse. And in short, Boorse just gives a very neutral definition of health. He just says health is simply the absence of disease. It's not like all this well-being stuff that's packed into the WHO definition. It's just the absence of disease. Now,
Jacob, I'm going to interrupt you very briefly because your slides are not advancing.
okay. So what slide are you seeing now?
We're still seeing your intro slide.
Oh, um, give me 1 second.
Yeah.
Let me, let me press the right button if I can, but I'm not sure what button to press.
Maybe try pressing escape and then play.
Yes, let's do that. Oh,
Worst case, you could just run it like this because now we can see it.
now you can
I
see
mean,
it.
it's not beautiful, but we can see the slides.
Right. Okay, so is it advancing now?
Just give it a, I mean, now we can see the World Health Organization definition. Just try pressing advance with the arrows on your keyboard. Usually arrows will do it in
Okay.
play mode
Yeah.
on Keynote.
For some reason, it is pausing when I hit the, let's try again. Yeah, it's just going to pause every time so what I might do is I'll just follow Eric's idea here. If you can see it
Sure.
now.
Yeah, no
Yeah.
problem.
Good. So we'll do it that way. Thanks for pausing me. And if there are any other technical things that come up, just jump in. Okay. So we've got Boorse's account of health on the one hand, and we've got this WHO account on the other. And what many people seem to think is that this somehow matters for the appropriate remit of public health. So some commentators seem to think that if WHO's account of health is the right one, then the remit of public health is expansive. Whereas if Boorse's account is the right one, then the remit of public health is constrained. It's constrained to doing things like um, preventive policies to keep diseases from increasing in incidence. rather than, for example, promoting income equality, for example. So my own view is that um, it's a kind of sort of a silent view on that debate, because I think my own view about this notion of health, the philosophical debate, is immaterial for public health practice. And that's basically because even with a narrow construal of health, that doesn't necessarily constrain the appropriate remit of public health. I'm going to come back to this idea a few times over the course of the next 30 minutes or so. But basically, most public health work, most public health officers are one way or another part of the state, arms of the state, and as such can be given expansive mandates if the state deems that appropriate. Um, and I think other considerations lend some support to this. So as most of you know in this audience, there's this big topic in public health, the so-called social determinants of health. So the social determinants of health are things like, income inequality contributing to health outcomes, that thereby entails that income inequality is itself a health issue that should be addressed by public health. Now, I think there should be some kinds of constraints on the remit of public health, but insofar as the state can just say the public health department should go do this or that, then even with a narrow construal of what health is, a public health department can have an expansive remit. So it's not obvious to me, it's not completely clear to me that philosophical debate about the nature of health has very strong implications for what the appropriate remit of public health is, or what kind of guidance public health departments should be giving, and so on. So I'm pretty much going to leave that aside. Now I'm sort of floating this as a very tentative thesis. It's not one that I'm committed to very strongly. I'd be happy to have my mind changed on this, but I'm going to just move past it really quickly. Okay, let's go to the public then. So there are very different views about what the public is in public health, and these views bring in ethical and political considerations. This can be seen in various kinds of mission statements in public health agencies. So here's the Canadian Public Health Association. They claim, "We champion health equity, social justice, and evidence-informed decision-making." So right up front, they're emphasizing the kind of political side of public health, equity promotion, social justice. If we contrast that with Public Health Agency of Canada, they have a much more kind of neutral account of what the public is, what they're aiming at. So Public Health Agency of Canada says we want to improve the health of all people and communities in Canada by addressing public health priorities through science, innovation, service delivery, and collaborative action. So there's much less of the kind of activism that we see in the Canadian Public Health Association mission statement. Where does that kind of view come from, this Canadian Public Health Association, this kind of activist view come from? I think it comes from different views about what the public is in public health. So this issue gets off the ground precisely because public health is concerned with population level measures. So measures that most of you are familiar with, things like birth rate, life expectancy, childhood mortality, disease frequencies, immunization rates, and so on. So public health is at its core, in the long history of public health, has been concerned with these statistical properties of populations. So, this is a nice pictorial representation of average ages across the world in different countries, where the kind of more forest-like colors are the older age life expectancies. The hotter colors are the lower age life expectancies. Canada's doing the best there. One of the key issues with population level measures is the worry that there's all sorts of ways in which population level aggregate summaries, like means, for example, hide or mask distributional properties. So for example, we've got England up here. It's not quite the dark green. The United Kingdom, it's not quite the dark green that Canada has, but it's up there. But when we zoom in on like a regional distribution of life expectancy in the United Kingdom, we see a great degree of regional variation. So what should public health officers in the United Kingdom be worried about? Should they be worried about life expectancy for the United Kingdom as a whole, just aggregated as a mean across the entire country? Should they be worried that actually there's this distribution across regions? So, former coal mining regions in the Northeast have really much lower life expectancies than they do in the kind of Cambridge, Oxford, London regions. And that's just regional distribution. So if we zoomed in on a particular region and then carved up life expectancies by, say, demographic features or socioeconomic features, we would see that even regional life expectancies are masking variation across those different kinds of groups. So what should we worry about? What kinds of numerical features of populations should public health people worry about? When we aggregate natural units like life expectancy or childhood mortality across a population, we mask variation. And that variation itself is something that motivates political angles on public health. So that's one reason why I think that there's this kind of political dimension to public health. And the other is this phenomenon that I've already mentioned, the social determinants of health. So as many of you know, work by people like Michael Marmot, for example, in this famous Whitehall study, have found that one's place in the kind of social hierarchy has a strong influence on health. And that's motivated many people to think that health, and public health in particular, is a political notion. And so then there's arisen a philosophical literature about the appropriate way of thinking about the public in public health. So the simplest way is just to essentially be what we could call a utilitarian, which is just to say the main appropriate goal of public health is efficiency oriented, and it's just to increase the average health of a public in a population. So without concern, without regard or without much regard to distributional properties. So that would mean that you could have policy interventions that increased the average numerical outcome of whatever it is you're interested in, while exacerbating differences between groups, as long as the intervention increased the outcome of concern on average. So that would be a kind of utilitarian approach, strict utilitarian approach. Egalitarianism, on the other hand, says, no, we should be really concerned with equality of outcomes in question. So if there are differences in subgroups across a population, then our policies should be geared towards intervening on those differences to get the worst case populations, subpopulations at the roughly equal level to other subpopulations. Prioritarianism is motivated by this distributional problem and says we should be really prioritizing our public health interventions on the kind of worst case groups to bring them up to a more functional level. Sufficientarianism says what public policy should be concerned with in health promotion is making sure that everybody is at a kind of minimum level of health functioning. So everybody has a kind of access to a basic bundle of goods that are health related one way or another. And libertarianism is kind of on the other end of these approaches. Libertarianism says the state should be concerned only with protecting members of a population from harming each other and shouldn't be using a heavy hand to have any kind of intervention on distributional properties across a population, except for controlling harm against others. So those various isms, these political positions about public health, have motivated a quite active philosophical literature. Now here's an example of a public health scientist expressing a kind of strong activist view. This is just one of the countless examples that we can find. This is Cass saying, it's hard to find a more powerful predictor of health than class, and it is thus an appropriate, if not obligatory, function of public health to reduce poverty, substandard housing conditions, and threats to a meaningful education, if for no other reason than to reduce the incidence of disease. These kinds of claims are easy to find in the literature. And so I think that public health scientists and public health officers um, are often motivated by these kinds of considerations. And I think the reason why they are is some of the population distributional issues that I was just talking about. So my own view here is again, this is a kind of modest view. It's not one that I've thought through as much as I'd like. But my own view is that the political angle on public health is just entirely dependent on one's views about political theory more generally. So the philosophical literature, what they do is they take off the shelf a well worked out philosophical view about political theory, and then they just apply it to topics in public health. And I think what I want to say here is that the proper goals of public health are just whatever goals the executive branch of a well-functioning democratic state ought to assign to public health. Because that's a kind of another way of putting this dependency point. The political angle on public health just leans entirely on political theory more generally. So if you have a political view which is, say, utilitarianism or founded on utilitarianism, then you'll be a utilitarian about public health issues. If you think that a well-functioning democratic state should have policies that are prioritarian in nature, then you'll just think that that's the case for public health as well. And so I'm not sure that public health officers themselves should be worried about these kinds of isms, egalitarianism, prioritarianism, and so on. In fact, I suppose I worry that these kinds of claims by Cass here, are relatively misguided. I'm worried that public health scientists and public health officers are um, are taking this kind of approach. Here's another sort of set of considerations that I think lend some support to that kind of politically silent angle. Um, Again, public health departments are typically arms of the state. Of course, there are non-governmental organizations that are involved in public health. That's clear. But most public health workers are one way or another employees of the state working for a branch of a public health agency. That's one way or another an arm of the state. And political goals can be, ought to be, and are pursued by other arms of the state. And a lot of public health work is just far removed from political goals, like, say, routine surveillance, infection control surveillance in a hospital, for example. Um, and many public health problems, they can be studied by public health officers. That's clear. Like, for example, wildfire smoke. So wildfire smoke is the kind of thing that public health officers can and should be studying. But the problem itself, the source of the problem and how to intervene on the problem, is typically out of the hands of public health officers. Okay, so I think what I want to say here on the notion of the public is that is this kind of politically silent view of public health. But again, I'm happy to have my mind changed on this. But that's where I'm leaning in this kind of conversation. Okay, so I know I'm sort of flashing through a bunch of big topics here, but what I really want to talk about is guidance. Okay, so whatever those goals of public health are, whatever the appropriate goals of public health are, public health guidance can be thought of as like a means to those ends. Public health guidance is like a set of tools to try to achieve those goals. And the way I've been thinking about public health guidance since Stephanie gave me this invitation is to carve up the public health guidance into three sort of types. There are three, the way I'm thinking about this is that there are broadly three kinds of public health guidance. There's informative guidance, there's persuasive guidance, and there's coercive guidance. Now, these are not extremely well-defined categories. They're not crystal clear distinctions. I think there's a lot of blurriness between these categories. But here's what I have in mind. So informative guidance are things like statistics, pamphlets, publications. Persuasive guidance are nudges, exaggerations, marketing campaigns. And coercive guidance is things like heavy incentives, liberty constraints, and mandates. And in the history of public health, we've seen lots of examples of all of these. So here, for example, like the Marmot Review that I've already mentioned, this comes out of this famous Whitehall study. Marmot found that British civil servants had health outcomes that were correlated to their rank in the civil service, suggesting that the higher up you are in a kind of social hierarchy, the better health outcomes you have. That's just a very sort of big, complicated set of science that Marmot did. He drew on a bunch of science and he put it all in the Marmot Review. Um, or here's a very simple way of a simple form of informative guidance from public health, just like hygiene, restaurant hygiene ratings. So this is just like a public health unit conveying information to the public that's supposed to be useful in the public's decision making. Persuasive public health guidance. Here I'm thinking about things like marketing campaigns. So one of my favorites is this Dumb Ways to Die video. If you haven't seen this, you've got to watch it. It's 3 minutes on YouTube. Dumb Ways to Die is a video campaign that was um, uh, rolled out by an Australian train company promoting rail safety. They were trying to decrease the amount of injuries that were connected to railway companies. And they hired a marketing campaign, they came up with a catchy tune and a catchy YouTube video, and it went viral. And the public health officers behind the campaign claimed that it decreased railway injuries by something like 30% over the following years. In any case, it's a very fun video. Or, think about these kinds of labeling campaigns that public health uses. This is clearly an attempt to try to persuade viewers, and this has been an old strategy in public health. Okay, so what do I mean by coercive public health guidance? So here's a kind of a good example of what I think well, arguably good. I'm still working this through, but the kind of guidance that public health authorities started to give policymakers going back to the mid part of the 19th century to eliminate smallpox. And basically, what what public health workers did was they formed committees and like associations to put pressure on policymakers to enact coercive legislation to enforce vaccination. And that started in European countries in the early part of the 19th century. The UK came around in the mid part of the 19th century. Um, and these laws were very coercive. So, for example, in some European countries, you couldn't get married unless you'd been vaccinated for smallpox. You could be fined, and those fines would increase in amounts the more times you were found to not be vaccinated. Childhood vaccine became the norm in these countries really quickly, and smallpox was eradicated. So if you think that the smallpox eradication campaign was a good thing, and you agree that the only way that could have been achieved was with this coercive set of policies that were promoted by public health officers in this sort of science advice policy interface, then you'll think that that form of guidance was it's a positive example of public health coercive guidance. Now, of course, on all three of those types of guidance, so here's just that list of examples that I just gave, and I'm taking these to be kind of positive examples of these three types of public health guidance. So I think that when the Canadian Food Inspection Agency puts those restaurant labels on restaurant windows, that's arguably a good thing. It's arguably a good thing that this Metro Trains Melbourne company promoted that Dumb Ways to Die video, saved many lives. The elimination of smallpox was clearly a good thing. So I'm taking these to be positive examples of these different forms of public health guidance. But I also think that there are clear examples of like negative examples too. So this is an example that Eric Winsberg, who's here with us, and I both love. Many of you, I think, will be familiar with this figure. This is the famous Report 9 from the Imperial College London modeling group, and that was published in March of 2020. And so this is the projection of critical care bed demand in the United Kingdom in the first months of COVID under various policy scenarios. So the black line is the do nothing scenario. Um, and the various colored lines are various policy interventions. And the red horizontal line was the critical care bed capacity in the United Kingdom. And so you see this just grand display of like horror about what's going to happen in the United Kingdom under well, a range of policy scenarios. But the worst, of course, was do nothing. And this is a sciencey looking figure. It's got an x-axis and a y-axis. It's got these really beautiful looking colored curves. It's got the look and feel of science. It's numbers on a graph. So it's it's advertising itself as being informative. Um, and I I think that it's a terrible example of public health informative guidance for a bunch of reasons. Eric Winsberg has published a lot on this, and other colleagues in philosophy. Robert Northcott has published a lot. The basic worry here is that the modeling work was hastily done. There were a lot of parameters that were poorly substantiated empirically. There were insufficient sensitivity analyses performed. The work wasn't submitted to peer review. It was like quickly handed to policymakers. And of course, the projections were not borne out. Okay. I realize that in my examples here, a couple of my examples here on what I'm taking to be kind of negative examples of public health guidance might be controversial, but that's okay. So here's an example of a persuasive public health form of public health guidance that I think is a kind of negative example. I think this can be said about many different disease screening campaigns. So this is a logo from a prostate disease screening campaign. And so many of you will be familiar with the concern about like some disease screening programs based on the various parameters of the disease screening program, like the probability of the disease being picked up in the screening, the probability of the disease in the population, the probability of false positives, those leading to follow-up tissue biopsies and so on. So there's certain diseases for which, when those parameters come together, a case can be made that more harm is done than good with the screening program. And of course, disease screening programs have big marketing campaigns behind them. Those campaigns are designed to persuade people to get screened. Coercive public health guidance, I think there's lots of really compelling examples of this in the history of public health. Here's one from British Columbia. So this is a law that was passed in 1933 on forced sexual sterilization. And I think there's a bunch of examples of this kind of law passed in Western countries in the early decades of the 20th century. And these were putatively justified on public health kinds of arguments, like eugenic kinds of arguments. Okay, so we've got these three kinds of public health guidance: informative, persuasive, and coercive. There are good examples of all of them. There are, I think, negative examples of all of them. Very coarse-grained pass at what one's attitude should be towards these kinds of these forms of guidance. Libertarians tend to be opposed to state coercion. So they're okay with state coercion as long as the coercion is intended to keep one person from harming another person. So libertarians are okay with, for example, disease quarantines because the person being quarantined is liable to harm other people. Or you can make a libertarian case for enforced vaccine mandates if you can argue that unvaccinated people are liable to harm others. But broadly construed, if you have a kind of libertarian bone in your body, you might be okay with informative public health guidance. You might be okay with persuasive public health guidance, but you're probably not going to be happy with coercive public health guidance, except for those harm conditions. Consequentialists, on the other hand, they just want to improve the best consequences for a population. So consequentialists just aren't opposed to state coercion. They'll say, we can use the coercive apparatus of the state to get good consequences. And that's exactly what public health groups in the mid part of the 19th century, early and mid part of the 19th century did with policymakers to eliminate smallpox. Okay, so I think one worry that I have is that once we start thinking about public health guidance in those three different ways, there's a worry that those ways just bleed into each other. And I think in public health in particular, it's very easy for those modes of guidance to bleed into each other, precisely because public health has this interesting mix of both science and policy. So I'm going to give you an example of what I mean in a moment. I've already given some examples that I think, in fact, really exemplify this bleeding. So here's this report 9 again. So the report, it was like a sciencey report. It was a report written by epidemiologists and handed to policymakers. But the report has, and this is one famous line from the report, which says lockdowns are the only viable strategy. The report basically said, look, if you don't enact these series of lockdown type policies, there's going to be this incredible harm done to society. And so the only real option is for you to lock down. So lockdown, of course, is not just an attempt to persuade people to stay home, but it involved the use of the kind of coercive power of the state to enforce people staying home and to enforce businesses staying closed and so on. So although I advertised this at first pass when I was going through the different types of public health guidance, I used this to illustrate the informative type. It in fact was of a coercive type. These public health scientists were explicitly trying to persuade policymakers to use the coercive power of the state. Okay, here's another example that I like, also from the COVID-19 pandemic. So this is a headline from the New York Times that was written by scientists who were responsible for this famous Bangladesh mask study. The Bangladesh mask study, so what they did was they took 600 villages in Bangladesh and randomly allocated the villages to either a mask group in which masks were distributed, there was training on how to wear masks, there were observation of how many people were wearing masks and so on. And then control villages, which didn't get that intervention. And it was huge. So there was like 350,000 subjects in this trial. And then the main outcome was just positive cases of COVID. So subjects had to have COVID symptoms, and then they had to have a positive PCR test. And when the results of the trial were published in Science, the world's most important science journal, and in that publication, the authors used the relative risk reduction measure. This is the number that I have in yellow here. So they said masks decrease the spread of COVID by 9.5%. That sounds pretty good. They didn't include the absolute risk reduction, and they didn't include the total positive number of cases in either group, which is shocking if you think about it. I mean, it was published in around September 2021. We're still at the height of COVID. There's still this big debate about whether or not we should be wearing masks. So here's the biggest, best study done on the effectiveness of mask wearing for COVID, published in Science, the world's best journal, and they don't include the total positive number of COVID cases. So commentators, statistics blogs, and so on asked for the data, and they got the data. And it turns out that the difference in positive number of in the number of cases, positive cases, was 20. So there's 1,106 in the control villages and 1,086 in the control villages, in the mask villages. So that, when calculated, gives you an absolute risk reduction of way less than 0.1%. Now, so here we've got this absolutely minuscule absolute risk reduction and a kind of middling relative risk reduction. The middling relative risk reduction was the one that was published in the Science publication. And then you've got this New York Times editorial saying masks work. Now, I'm going to skip over some technical arguments here, but there's this background technical literature that I've been contributing to that argues that absolute measures, measures like the absolute risk reduction, or if you've got a continuous variable mean difference, those are absolute measures. And those can be informative for inference makers and for decision makers. But relative measures like relative risk reduction, risk ratio, odds ratio, these are not just uninformative, they're positively misleading. So these are a couple of articles in which I make that case, but there's other people that are arguing for this kind of thing as well. Um, so, so if we go back to the Bangladesh mask study with that kind of technical background in mind, what we have is the scientists in question reporting their results using a measure which is just outright misleading, and withholding a measure which is the actual informative measure. Why did they do that? And why did they write this New York Times editorial? Arguably, it's because they were trying to both persuade and perhaps coerce. So the study itself in the New York Times editorial, and certainly the New York Times editorial, was more in the mode of persuasion rather than information. I would go so far as to say that the science publication itself was more in the on the persuasion side rather than the kind of information side of public health guidance. That's because of their use of the relative measure. Now, public health seems to love relative measures. So when you look at, for example, the effectiveness, like trials on the effectiveness of disease screening programs, for example, they're almost always reported using relative measures. And I suppose that might be because here's a quote from some of my scholarly enemies. um, so these authors argue that we should use relative measures because most people lack a grasp of probability and statistics, and we can get people to do things that we want when we use relative measures, because relative measures are typically bigger than absolute measures. And there's empirical evidence that shows this. So there's empirical evidence that shows that when you give doctors and patients absolute measures, they're less likely to prescribe or consume medications than they are when they're given relative measures. So, so if that's why we're using relative measures to get people to do things that we want them to do, then we're sort of, blurring those public health modes of guidance. We're sort of blurring, we are kind of pretending to be in the informative mode of public health guidance, but we're actually in the persuasion mode. And so an idea that I've been kind of toying around with in the weeks since Stephanie invited me to give this talk is this kind of meta level principle that when you're engaged in public health guidance, you ought to be just upfront and honest about which of those modes of public health guidance you're engaged in. So with that dumb ways to die video, or with the labels on the cigarette packages, there's no question at all in anyone's mind about what the public health officers behind those campaigns are up to. They're trying to persuade you. They're trying to change your behavior. That's sort of honest in its sort of in its aim. But when you do something like report a relative measure because you want to change people's behavior, what you're doing is you're advertising yourself as giving information because it's a number. But you're not actually engaged in delivering information because a relative measure is not informative. Instead, what you're trying to do, at least if you follow the kind of line of thinking here by Hofer and Krauss, is you're trying to change people's behaviors, or you're engaged in persuasion. So to rewind a little bit, if you agree with me that all three of those modes of public health guidance, to inform, to persuade, and to coerce, they can all be permissible in some circumstances. If you agree with me on that, then you might think, well, then anything goes. There's no problem with public health using relative measures to persuade, because we've already agreed that the persuasion mode of guidance is fine. But I think a meta-level principle here is that we should at least be upfront we should at least be transparent about the kind of mode that we're engaged in. So when the public health officers went to the European policymakers in the first decades of the 19th century and said, you've got to enact vaccination enforcement laws, there was no question about what they were trying to do. It was clear they were trying to convince policymakers to do something that policymakers had never done before, to use the coercive power of the state in that way. But when we have the kind of work that I've been complaining about in the last few minutes, there's a kind of blurring in the modes of guidance that's offered. So Stephanie kindly mentioned this book that I've just finished writing, and that it'll come out in a few months. But there's a chapter in that book in which I focus on scientific assertions generally, of which I think public health guidance is a kind of type of scientific assertion. So a scientific assertion is just saying something about the way the world is in any kind of venue, like a publication, a report to a policymaker, one scientist talking to another. And I give these two kinds of, I argue for these two principles, that scientific assertions should be both justified and informative. And I give a particular view about what I mean by both of those. I'm not gonna bore you with the details. But when we come back to the two examples that I've been using to illustrate here, so here we've got this figure that is advertising itself as being informative when it's not really informative. And if you follow the critics of this work, then you'll also think that the predictions here, like the actual content on the graph, is not justified. The scientific work that went into the development of this model just doesn't support this representation of the predictions of the model. And then same with the Bangladesh mask study. So the Bangladesh mask study is very much unlike the Imperial College London modeling group in the sense that it was an incredible study. It was really well done. It was a big randomized trial. It was fairly carefully controlled. So the work itself, the underlying kind of scientific work, could have been justificatory. It just didn't justify the kind of public-facing statements that came out of the work. Okay, so just to wrap up, so I started by focusing on health, but I went through that really, really quickly. And then I moved to speak in a little bit more detail about this notion of the public, and ended up having a kind of sort of silent view about the political angle of public health. But then I spent most of my time talking about this notion of guidance. And so the idea that I'm floating is that there are these three types of public health guidance: to inform, to persuade, to coerce. I'm pretty sure they can all be okay in certain circumstances. It's just that public health officers should be sort of upfront about what kind of mode of guidance they're offering when they offer it. And so I'm going to wrap up there. There's some of the references from some of the work that I've been mentioning, and those can be found on my website, which is behind that QR code there. And I'd love to hear from you by email or during our conversation now, if you've got comments or questions for me. Thanks.
Thank you so much, Jacob. I'll let you stop sharing so that we can see the group here. Big round of applause for Jacob's presentation. I want to start off by acknowledging the question in the chat, which comes from Jeff Brook. Jeff, are you still here? And would you like to ask the question yourself, or shall I read it out? And then I will go to you, Eric Winsberg.
Well, hi, everybody. I'm happy for you to read it out. Thanks very much, Jacob, for this talk. It's really great to put these things down in a way that we can all think about. So yeah, I was just sort of musing on this other aspect that we're fixated on, which was measuring things. And I thought maybe you could comment on that a bit more.
Yeah, thanks for that. I mean, so unfortunately, I've got nothing really to offer here that I'm sure most of you haven't already thought about in great detail already. So there's this huge problem of like amalgamating natural units, right, to allow for comparisons and policy guidance. So if you've got natural units like birth rate, death rate, infections, vaccination rate, and so on, there's no natural sense in which you can sort of combine these various measures into an overall measure of public health. And so what public health scientists have done is tried to articulate summary measures, things like DALYs and QALYs. And so, quality adjusted life year, that's an attempt to get a summary measure that somehow we can quantify health in a population that gets beyond that problem of amalgamating natural units. And then there's a bunch of problems with those summary measures. So I'm not a professional in that area. I don't have much more to say other than just to kind of re-articulate the problem. But yeah, it's an important one. Thank you.
Thank you.
Thank you. Thank you, Jacob. And I think on that particular question, we might want to revisit and talk to some of our members here today, like Dr. Emily Brigham, who's a respirologist. So we can perhaps revisit that question momentarily. But because Jacob mentioned Eric Winsberg's work, I want to, and his hand is up, I want to give Eric a chance to talk. For those of you who maybe don't know Eric, he's actually a colleague of Professor Stegenga at the University of Cambridge. Eric, go ahead.
Hey, Jacob, thanks for that. That was great. I couldn't agree more as a kind of, basic regulative ideal with your political quietism claim. I think you're absolutely right that, what public health ought to do, whether it ought to be, expansive or whatever, it's an arm of the state, and this is just a political theory question. And that what they should just do, of course, is just respond to whatever democratically legitimate agents tell them to do. I think that's absolutely right as an ideal, but I want to press on it a little bit as whether it's realistic in practice. Um, and so draw attention to a couple things. So for one, there's a sort of literature in like public choice theory about precisely this kind of question, not with respect to public health, but with respect to bureaucrats in general. Right. Because you get this phenomenon in politics where, Donald Trump gets elected, Donald Trump appoints Robert Kennedy Jr., Robert Kennedy Jr. Appoints someone else. That person becomes, a person for life, and then begins to have a certain amount of, bureaucratic power that has democratic legitimacy in its origin, but becomes entrenched. So that's one phenomenon. Then I just want to sort of mention like three things that have been said to me at Cambridge, or one was said to Stephanie, but in response to joint work of ours. So when I gave my first talk at Cambridge, I think you were there for this. I was talking about the ICL model and all that, and I was talking about the value ladenness of science, and I said something like, um, scientists are special with respect to their expertise, but they're not they have no special, um, you know, uh, no special power. They have no special ability to discern what the right values are. They have no special ability to discern the kinds of questions that you were asking, right? And somebody, I think I know who it was, but I'm not sure, so I won't say name, said, but isn't that wrong? Because wasn't Neil Ferguson a member of SAGE? And isn't SAGE, a democratically appointed and therefore politically legitimate body? Okay. And then when Stephanie gave a talk about public health guidance, and was talking about the ways in which it's value laden, they're kind of similar to some of the things you were saying, and talking about Hasek said, but aren't there certain values built into the idea of public health? So he was suggesting that I take it public health is intrinsically egalitarian, communitarian. It's built into the word public there. And then, like, for example, um, uh, can people hear me?
Yeah.
Yeah, okay, sorry. I just got a weird message from Zoom saying that I hadn't spoken. And then Stephen John has this line that I've heard him give a number of times, right? That like if you want to know whether you should get a surgery or not, you should consult your doctor who will prioritize your well-being, and your banker who will prioritize your financial security or whatever. And you should expect them because of their professional status, right, to give advice that reflects those underlying values. Okay, now I want to then combine that with um, something that I think you said, which I completely agree with. I think I may agree with it more even than maybe you do, which is that there's a blurry line between persuasion, uh, so what were the three things, like, just communication, persuasion, and coercion? And that not only that, right? You can I think find cases like the ICL model where, um, or the bank, the way the Bangladesh mask study was reported, where it's pretty obvious that like the way the information was being reported was, you know, but I think it's kind of impossible to completely avoid that, right? I think any attempt to inform is gonna involve some um is gonna involve some you know
Imposing of values.
imposing of values, some like, presumption that you're informing is going to bleed into persuasion, which might then bleed into coercion. Okay. So having said all that, is there then not something to be said for public health to not punt on this question? In other words, should public health not be a little bit reflective about what some combination of these two questions, what they think the right political theory is that ought to be there for public health, and what they think the public's is, and be adapted.
Eric may be frozen. So Jacob, did you glean a question from that so far? And if so, do you want to go ahead and give your
Yeah.
thoughts?
Yeah. I think Eric's frozen on my side too, but I certainly got the gist of there's multiple moving parts there, but I think I got it. Yeah. So I mean, he started with this worry about my kind of politically silent view about public
Themselves
health.
to some, interpolation of that.
Eric,
Because
sorry, Eric, I'm going to interrupt you because you froze for a number of moments. So I've asked Jacob to go ahead and respond to the question that's, I think we know effectively what you're
sorry,
on.
I don't have internet where I am, and I'm using my phone, and I got a phone call which disconnected my
Oh,
internet.
So
okay. We'll just ask
Um,
you to sort of wrap it up there, and Jacob's going to respond now.
yeah, I think I got the gist of the question, Eric, but let me try to answer, and then we'll see if that satisfies you. So, I mean, you started with this worry about my politically silent view might be a kind of ideal, but in a non-ideal circumstance it might be problematic. And I mean, you used the example of RFK, and yeah, I mean, I think that's exactly right. So I kind of hedged. I gave a cheap hedge when I was presenting the work, which I wanted to say something like in a well-functioning democracy. Um, we should have this politically silent view of public health. But of course, in a dysfunctional political context, um, I think we can imagine arguments that would support a kind of more politically voiced view of public health. And I think the example of RFK is a good one. So I've been thinking about this problem for the last couple of weeks. One thing to say, just a kind of sort of more kind of down to earth response, is that in a in at least a semi well functioning state, some institutions will have these relatively long standing safeguards that are sort of hard to change. And so if there's this sort of moment of dysfunction, like now you've got RFK, um, then at the very least, like the standing rules for new drug regulation at the FDA can't be just overturned overnight, right? So it takes a little bit of heavy lifting to cause.
We've got terrible luck today for freezing. The internet is taking a day off.
Freeze? Am I okay?
You did freeze for a second there, but I think it seems like you're back. So please
Oh,
go
right.
ahead.
Okay. All right. Okay. Um, And then just to get to the next point, so yeah, I'm not sure I follow this view that like public health is intrinsically political. I'm reading this interesting history of the eradication of smallpox now, and it was really interesting the debates that were had between the policymakers and the public health officers at the time. That public health officers were um, of course, they were concerned with political questions, but they were concerned with political questions qua political question, not qua public health problem. So they were worried that smallpox rates were greater in poor areas of London than they were in the kind of rich suburbs. Um, and when they were pushing policymakers to enact coercive vaccination laws, everybody recognized what a momentous decision this was. It was not a kind of easy thing. Um, it was it was a challenging thing to convince policymakers to do that. So it's not so obvious to me that the kind of remit of public health is sort of obviously political. And then to get to your next point about like, so I've got this idea that public health guidance can be informative, it can be persuasive, it can be coercive. If we go with one view about the way values influence science, one might say there just can't be a pure informative mode of guidance. There's always going to be some kind of value influence on, particularly in a policy-facing context like public health. And yeah, even if that were true, which I'm not sure it is, but even if it were true, it would still be the case that, and I think you and I are in agreement on this, that reflective scientists could be reflecting on that and do their best to manage it one way or the other. And so, yeah, I'm not sure I'd want to go so far as to say all scientific guidance or all public health guidance is necessarily value-laden. I don't believe that. But even if it were, then I'd want to say public health officers should be doing what they can to at least be upfront with the kind of guidance that they're giving. So if they're in the kind of persuasion business, then just be clear that they're in the persuasion business. And if they're in the deliver information business, then try to do it in a way which is at least as value-free as possible.
Thank you, Jacob. And I see that there's no hands or chat questions up at this moment. So I want to encourage you to go ahead and think something through if you'd like to pose a question to Jacob. But in the meantime, Jacob, I want to bring up a couple of things that are specific to wildfire smoke and get your thoughts on them. So one thing that's very interesting to me about wildfire smoke guidance specifically is that it speaks right now simultaneously to the individual and to the policymaker. So a lot of what we see in at least what I recognize as wildfire smoke guidance, including sort of your very standard fact sheet, there are really recommendations for individual health behaviors. So things like running an air filter or staying indoors with the windows and doors closed when the air quality exceeds a certain level. And for me, I see, of course, that those have a clear parallel with clinical guidance, where actually the received view is that the decision should be informed by the patient's values. Now, of course, there's a debate around that, as you know very well, but given the sort of focus on patient-centered care, there's been a lot more basic consensus that you should be approaching the patient with a question relative to their own values around the problem. So I wonder if you have any thoughts vis-a-vis, you've made the point that public health guidance should try to wear it on its sleeve, whether it's trying to be informative versus persuasive. And I wonder if you have thoughts on, should it be pulling back from that? Should it be making the judgment that persuasion isn't appropriate for individual level guidance because of the need to acknowledge the individual's potential values around the issue? Is that something that maybe public health guidance should be thinking about doing? And can you maybe say a little bit about how you think the role of uncertainty or what role uncertainty plays. Because of course, in the clinical context, you might feel more comfortable persuading a patient what to do if you've got a huge amount of evidence in support of what outcome will follow that action. And just to kind of give a bit of background, in the wildfire smoke context, there are proposed interventions where the quality of the evidence is still under questioning. So with respect to masks, it's not very clear. The standard of evidence is not very high with respect to the use of air filters, same kind of issue. So I wonder if you have comments on that in the wildfire smoke context specifically.
Oh, thanks. Yeah, this is a really great question. And okay, so here's how I would approach it. Okay, so suppose we adopt this framework that I've got of these three different types of public health guidance, informative, persuasive, and coercive. And suppose we grant, I think, a sort of plausible assumption that the legitimacy of those modes of guidance goes down as you go down the list. So there's sort of no problem about scientists, public health officers being informative. Being persuasive, now we're in a territory where it starts to raise certain questions, like should we allow nudges? Should we allow like subliminal messages in movie theaters to get people to eat more carrots rather than popcorn? So the kind of persuasion tactics start to at least call out for justification that the informative tactics don't call out for. And then clearly that's the case for coercion. So as we go down that kind of list of modes of public health guidance, we need more and more justification for what we're doing. And I think that justification comes from one of the dimensions that you just mentioned, namely certainty. So that's, I think, one really important dimension. And I think the other is the magnitude of what we're intervening on. So I think it's a plausible thought that basic principles that we're committed to, like don't use the state power to coerce people. Basic principles can be modulated or violated in response to emergencies, in response to grave threats. So that's one way in which we could get a justification for public health officers engaging in either persuasion or coercion. What we'd want is a relatively high degree of certainty that the threat is a real threat, a relatively high degree of certainty that interventions can modulate that threat, and that the threat has at least a minimum threshold of magnitude. So this is a sort of standard way of thinking about risk assessment and intervention on risk. We can use more and more sort of coercive power, the greater the sort of threat is that we're intervening on. And I think that's what justifies the public health plan to eliminate the successful program to eliminate smallpox, right? Smallpox was this incredibly terrible thing. By the middle of the 19th century, it's killing tens of millions of people and disfiguring many more. And there was this easy, relatively safe, relatively cheap intervention available that could just get rid of it all. So the certainty side was really high, like the effectiveness of the smallpox vaccine by 1850 was a no-brainer. So the certainty of the threat was high, the certainty of the intervention was high, and the magnitude of the threat was really high. So now we can go with coercion. Was that all true for the COVID-19 pandemic? There, I think things get a little bit, I mean, in my mind, things are not as clear as they were in many people's minds 4 or 5 years ago. I'm not sure that we should have gotten down to the kind of level of coercion that we did. Now, what about wildfire smoke? I'm no expert, so I'd be curious to hear what you think about it. But I think that's the framework that I would take, and I like the dimension of certainty. We want some not strict certainty, of course. We're dealing with probabilities here, but some middling or high degree of certainty that the threat's a real threat, that the threat has this great magnitude, and that our intervention can modulate that threat.
Thanks for that answer. I see that Lydia Ma has her hand up. And actually, prior to that, I also saw Kate Johnson. Kate Johnson, are you still wanting to ask something? I'll perhaps go to Lydia first, and then if Kate is still around, I'll go to you next, okay? Please go ahead, Lydia.
Yeah, hi. Hello. Thank you very much, Jacob. I'm Lydia Ma with the National Collaborating Center for Environmental Health. And my question is better spoken than written in a chat and make everybody read it. So that's why I'm um, bold and uncover my camera to ask this. So first, as I said, I thank you for sharing your expertise with us through your talk. Certainly help expand my thinking around public health guidance. And I really appreciate the three principles you mentioned: the information, persuasion, coercion. In my mind, the degrees of which the inter-influence and perhaps some instances of being not independent of one another is there for me. My question, and maybe this is a bit of out of scope for your presentation because yours is not a how-to talk, is this. It's about tailoring messages and audience segmentation. Perhaps in not thinking about one audience, these principles applying to one audience, but many with their unique needs and wants and requirements. So in other words, it's not a one size fits all. In the context of what Stephanie brought up with this wildfire smoke context and health, maybe tailoring isn't so relevant here. I mean, the impacts on health is impacts on health, but I'd still find that if I don't ask this question here, I'm not sure where else I can ask it. So look forward to your insights, further insights. Thank you.
Thank you very much for that question. So I completely agree. So I very briefly at the very end of the talk mentioned these two principles that I think apply to scientific assertions. One is justification and one is informativeness. And one way to put your question is, and I completely agree with this, is that the look and feel of those principles, how they're actually implemented, what justification amounts to, and what being informative amounts to, depends on the context of your interlocutor, depends on the features of your audience. And so, I mean, we know that people's degree of scientific background varies widely, people's numeracy varies widely. We know that the decision that a policymaker has to make is a lot different than the decision, like going back to Stephanie's question, the decision that a particular person who's deciding whether or not to put such and such filter in their house. So the kinds of the backgrounds, the decisions that different interlocutors are facing just varies widely. And so what those principles say for a particular act of guidance will differ depending on the context of one's audience. And that can be tricky, of course, because we don't always know who our audience is going to be. But I think sometimes we can make a fairly good guess. So for example, to go back to the Bangladesh mask study, I mean, in September of 2021, when you're publishing the results of this huge trial in Science, you can make a pretty well-informed prediction about who your audience is going to be. And when you publish an editorial in the New York Times, you can make a pretty good guess about who your audience is going to be. So we can make a fairly good guess about the sort of various features of our different kinds of audiences. And of course, the way we communicate to those audiences should be tailored according to the context. Yeah, thank you.
Just going to call on Kate Johnson to see if, there you go. Did you want to ask a question, Kate?
Sure, I did. Thank you very much for this really thought-provoking talk. First of all, my question, I was a little too slow in finding the raise hand gesture, but it was actually just to follow up on something that you said in response to Eric's question around public health guidance that is not value-laden. And I just wanted to sort of kind of hone down a specific example on that. But you really answered that, I think, in response to Stephanie's question, that from what I understand, an example of a not value-laden, or at least less value-laden public health decision would be if they fill those criteria around high magnitude event with at least reasonably low uncertainty, and we expect that the intervention can actually modify that risk. So perhaps I could just ask you to clarify, if we're thinking about things that we can at least expect to be less value laden, we would be evaluating it on that spectrum.
Yeah, I think so. I think I'm friendly to that way of thinking about things. Now, I'm sort of like dancing around the issue a little bit here because there's this kind of boutique debate among our colleagues in philosophy of science. And the kind of status quo view in that debate is that sort of all of science is value laden. And anytime a scientist makes an assertion in any context, it's value laden. And then there are like slightly more modest versions of that thesis. And I'm not part of that status quo, so I think that at least pursuing the goal of value freedom is a worthwhile, feasible, noble thing for scientists to do, and they can achieve it in particular circumstances. And the kind of circumstance that you were just describing, I think, is one of them. At the very least, if scientists just articulated all those dimensions in an appropriate way, so they just articulated the degrees of certainty involved, their estimation of the magnitude of the risk, their estimation of the effectiveness of the intervention, if those were all articulated in fair ways, then that would at least be a step towards value freedom. Yeah. Thanks.
Thank you.
Since there's no questions for right now, I'm going to go ahead and extend that talk a little bit. And it's possible that Eric Winsberg will want to jump in again. Some of you will know that Eric and I both write on this topic as well. And we actually have the view that Jacob is flagging as not precisely his own. So Jacob, I think you're far more on the side of, oh, you know, there's an important way in which we actually can and should strive for value freedom. Whereas Eric and I are much more on the side of there's really no way to get the values out because of the fact, and Eric has pressed this point very nicely in a recent paper, you know, decisions, according to the most very basic decision theory that almost everybody will agree with, decisions involve values. You can't make a decision go on just a belief. You've got to have some sense of the desirability weights that you attach to the outcomes. And the scientific process just involves so many decisions that throughout the process, what you end up with is a value-laden product. So when it comes to public health guidance, and here I'll attach to a specific example, let's say the question of, are HEPA air filters, you know, effective at improving health outcomes? You know, you've got a number of points where you're having to decide important aspects of this claim. One of them being, well, do we have to show that it really improves health outcomes per se, or is it okay for us to go with a proxy? So right now, for example, as far as I know, there's really no literature that can show that HEPA air filters improve health outcomes, you know, around the context of wildfire smoke. There's some literature that will show, you know, that it, for example, will of course improve the air quality, but we haven't yet drawn the link. So that's just one example. And then, of course, when you're creating something like a fact sheet around wildfire smoke, you've got to make this judgment about, well, what exactly do you say about HEPA filters? And one interesting kind of way to think about this is the way that the guidance is going to simultaneously speak both to individuals and to policymakers. So, but of course, there's a lot of same considerations. You know, for example, if I'm an individual that's on a limited budget, is it actually the best choice for me to go ahead and invest in an air filter when perhaps that will take funds away from other things that I might do that would better advance the goal of improving my health? And that's another aspect of the question that I think is interesting in the context of wildfire smoke. There's the question of, should the government be funding distribution programs for air filters? And if those are not shown to be cost effective, and my understanding is right now, they don't look to be particularly cost effective under most conditions, should they be recommending them to individuals? So with that mouthful, would you want to say anything else?
Yeah, I mean, so I'll be brief about it because it's a good question, and I know that, I mean, you're sort of you're putting your finger on a tough issue for me. I mean, I think in brief, what I'll say is just for those of you that are interested in this values and science literature, you'll know that the various theses on offer are often articulated in very domain general terms. So arguments like the one that you just gave will be described, and then the conclusion will be something like, therefore science is value laden. And I think that that's a kind of fishy move, because the kind of context that you were describing is this very practical context. It's a very it's a policy-facing context. Individuals have to decide whether or not to buy HEPA filters. Policymakers need to decide what to say about them, what kind of guidance to give. And so these are all practical decisions, and practical decisions clearly are value laden in that sense. And so I think one could agree with all the setup of that whole of the whole question, and still say that for most of science doesn't have that kind of structure. So one way to put it is that kind of argument that you were giving requires as premises that one can predict the consequences of being wrong, and that one is in an action guiding or policy facing context. And if those don't hold, then the argument doesn't go through. Now, not everybody agrees with that, and Eric Winsberg has published papers arguing against that. So I think that's where the real action is in that debate, is whether or not one thinks that those are in fact operative premises of that argument or not. Yeah.
Eric, did you want to maybe chip in on that topic as well?
Sure, I'm happy to. So I just want to I think there's three different responses on offer there, and I want to say something a little bit back to them. So one I basically agree with. I only have a kind of pedantic reply to it. And I take it this was basically Kate's point, right? Suppose I'm giving the following public health guidance. Don't step in front of moving trains. Okay, is there uncertainty around that? No. I'm virtually morally certain that stepping in front of a moving train has bad outcomes. And I'm virtually certain that it has very little positive outcomes. And I'm almost positive that everybody in the world shares my values enough that my degree of certainty that stepping in front of a moving train is a bad idea. Now, of course, the pedantic reply is, well, there is a set of values you could have where even if my certainty is 0.99999999999 that stepping in front of a moving train will kill you, that 0.00001 will matter if you really, really value jumping in front of moving trains and don't value your life very much. Okay, that's just a pedantic reply. But the more relevant reply, I think, is cases like that are pretty rare in actual public health, in actual science. There was a second. Yeah, go ahead.
Well, so that little move that you made there is the slippery move that I think happens a lot in the literature. So you said that's rare in public health, it's rare in science, right? But those are different things, right? So it's true that it might be rare in public health, but might not be rare in most of science. Right?
Okay, yeah.
Can I just jump in there? Can I maybe I want to know Jacob's opinion on this before you move forward. How far back do you think we need to go, Jacob, before we have, because what you were saying is it's value laden as soon as we get pretty close to the practical context, right? But so how far upstream do we need to go for you to be recognizing a relatively value-free sort of assertion?
Yeah, great. Yeah, I like that way of putting the question. So yeah, a lot of the values in science literature thinks that really what's at stake is like this particular inference that's being made by this particular scientist, or this claim that this particular scientist is making to this particular policymaker. And I suppose I don't really think about science that way. I mean, of course, science is filled with those sorts of moments. But the kind of, when we zoom out in time, we think about the great products of science, like the great products of science, like the contributions to our stock of scientific knowledge, aren't composed of these like particular inferences that this scientist made, or these particular statements that that scientist made, but rather it's this kind of group level, social, emergent property, emergent set of contributions to the stock of scientific knowledge. So when I think like, the macro structure of DNA is a double helix, there's a claim that's just clearly not value laden, right? And it's an example of the very best that science has to offer. When I think when I think about the predictions that the ICL group made in the spring of 2020, that's just not the very best of what science has to offer, right? It's an example of the very worst that science has to offer. So when we're thinking, is science value laden? And we've got these examples of the best that science has to offer and the worst that science has to offer, we can just look to some of the best. Now, it might be that we have to rewind, we have to go to your question, we have to go back quite far, right? So the structure of DNA is a double helix. I'm going way back now, right? I'm going back in time, but I'm also way far away from the science policy interface. If we're dealing with questions like, are HEPA air filters effective at improving health outcomes during for wildfire smoke? That's I mean, we're clearly so close to the science policy interface that the practical implications of what's at stake will be embedded in the science. And I'm, intellectually, I think that that's a reasonable thing to say. So I'm actually with you guys on that. But surely you don't want to say that the structure of DNA is a double helix is a value-laden claim about, science.
Can I join?
Please go ahead. Yeah.
Yeah. So of course I don't want to say the structure of DNA, but I think I would lean much more heavily on because it's been around for 75 years and the uncertainty is almost zero than I would on because it's not at the science policy interface. And I actually think your student, Adrian Erasmus, gave a great talk in Pittsburgh a few weeks ago, I think making a really good case for this, right? So he was talking about a case which does have some policy implications, but it wasn't really relevant to it's the role that amylin plaque plays in dementia. And he was just, I think, very persuasively arguing that um, you know, it, in in a situation where the science is funded and where there's institutional, people need jobs and whatever, that you get a kind of people's values around like just wanting employment and wanting to get grant money and stuff like that make it very difficult for them to articulate hypotheses that aren't part of the group think. So I don't think that you need, even though actually that particular case did it, I think you get that, you could run Adrian's argument just as well with with high energy physics and the claim that like the energy level of the LHC was going to be where you were going to find supersymmetry. Something with zero policy implications, right? Other than spending 100 million euros on a super collider. Right,
Okay,
that was the only policy implication there.
Yeah, I'm on board with you here, Eric. And then thanks for the shout out to Adrian's work. So, but I think it's important to remember here though that values in science debate is it's a normative debate, not a descriptive debate, right? So the critics of the value-free ideal are saying science should be value-laden. They're not just saying that here are these cases in which science is value-laden, right? So I'm totally on board with you on the high energy physics example. There are these worries about groupthink, worries about funding distribution.
So good. So I just want to emphasize that the DNA case, of course I agree with you. DNA is a double helix, no values in that. But that's because of how old it is and how well established it is, not because of its lack of policy interface.
Yeah.
And then the third there's the third component, which is, I think you were saying, well, even in these more difficult cases, you can strive for the value of freedom by articulating the uncertainty and articulating and I of course agree that one should do that. I just have I guess I have pretty strong views about the degree to which one can, in a value-free way, articulate uncertainty.
Yeah.
I think that in his heart of hearts, Ferguson probably knew there was more uncertainty than he was conveying in that diagram. But I also think that because of his values, in his heart of hearts, he thought there was less uncertainty there than I did.
That's right. Yeah. I think you're right.
I think your values will influence your assessment of what the uncertainty is.
Yeah. So I think I'm on board with you. In fact, we were at a conference together with Neil Ferguson, and he exactly said that he's the kind of scientist who who thinks that a scientist should always convey uncertainty and should never tell policymakers what to do, right? Which,
well, he was. I mean, given. I wish I'd had the copy of the report now in front of me, because given the line that you quoted from it, that was clearly not true. But when you say there's only one possible policy choice here, then you've violated that norm. But anyway,
exactly.
But yeah, okay, good.
Yeah, thanks, sir.
I'm gonna hop now and try to wind this down because it's 10:32. Jacob, I really want to thank you again for being with us today. I think we've touched on a lot of dimensions of this topic that we're going to have to revisit throughout the Lungs on Fire project. We've talked about uncertainty. We've talked about the difference between informativeness and persuasiveness and coercion. And I really hope that people will keep these things in mind.
Thanks so much for the invitation and all the questions. And please do get in touch with me by email, maybe through Stephanie, if you've got any comments or questions for me. Thanks. Thanks all.
Again, Jacob. And thanks everyone for being here. I'm going to stop the recording.
All right.